Erectile dysfunction, ED, is often misunderstood as merely a sexual performance issue. However, modern cardiovascular and urological research clearly demonstrates that ED can be an early clinical marker of systemic vascular disease. In many men, erectile dysfunction appears 3 to 5 years before a heart attack, stroke, or diagnosis of coronary artery disease. This makes ED not just a quality of life issue, but a potential life-saving early warning signal. Understanding erectile dysfunction is defined as the persistent inability to achieve or maintain an erection sufficient for satisfactory sexual performance for at least 3 months. Epidemiology: over 30 million men in the United States are affected, or more than 50% of men between 40 to 70 experience some degree of ED. Prevalence increases with age, diabetes, hypertension, and obesity. But ED is not simply a consequence of aging. It is primarily a vascular disorder. How an erection works. The vascular mechanism: an erection is a neurovascular event involving 1. Brain stimulation, 2. Nerve signaling, 3. Nitric oxide release, 4. Smooth muscle relaxation, 5. Increased arterial inflow, 6. Venous compression to maintain rigidity. Nitric oxide, NO, is the key molecule responsible for vasodilation. Healthy endothelium is required for adequate NO production. If endothelial dysfunction develops, erections weaken. The same endothelial dysfunction also drives coronary artery disease. What is coronary artery disease? Coronary artery disease, CAD, occurs when cholesterol-rich plaque accumulates inside coronary arteries. This process is called atherosclerosis. Stages include endothelial injury, LDL oxidation, inflammatory cell infiltration, plaque formation, progressive narrowing, a plaque rupture. Heart attack. Atherosclerosis is systemic, meaning it affects the entire vascular tree, including penile arteries. The artery size hypothesis: penile arteries, 1 to 2 millimeters diameter. Coronary arteries, 3 to 4 millimeters diameter. Because penile arteries are smaller, they become obstructed earlier the disease process. A 30 to 40% plaque burden may severely limit penile blood flow but still be silent in coronary arteries. Therefore, ED may precede symptomatic heart disease by years. Scientific evidence supporting the link: major meta-analyses show 44% increased risk of cardiovascular events, 62% increased risk of myocardial infarction, 39% increased risk of stroke, 25% increased risk of all-cause mortality. The Princeton 3 consensus identifies ED as an independent risk marker or cardiovascular disease. Men presenting with ED should undergo cardiovascular risk assessment even if asymptomatic. Shared risk factors: both ED and heart disease share identical risk profiles. Hypertension damages arterial lining. Diabetes causes neuropathy and vascular injury. Hyperlipidemia promotes plaque formation. Smoking accelerates endothelial dysfunction. Obesity, linked to inflammation and low testosterone. A sedentary lifestyle reduces vascular elasticity and metabolic syndrome. Insulin resistance and inflammation. These factors collectively impair nitric oxide production and vascular responsiveness. Endothelial dysfunction. The common pathway: the endothelium regulates vascular tone and thrombosis. Damage leads to reduced nitric oxide, increased oxidative stress, inflammation, prothrombotic state. Endothelial dysfunction is the earliest detectable stage of atherosclerosis and is often first noticed as erectile problems. Timeline: how many years before heart disease? Clinical data suggest ED appears approximately 3 to 5 years before a major cardiac event. In men under 50, ED is an especially strong predictor of future cardiovascular disease. This provides a crucial prevention window. Differentiating psychological versus vascular. Psychological ED: sudden onset, situational, normal morning erections. Vascular ED: gradual onset to persistent, reduced nocturnal erections, associated with risk factors. Clinical evaluation is essential to determine etiology. Cardiovascular screening recommendations: men with persistent ED should be evaluated for blood pressure, fasting glucose/HbA1c, lipid profile, body mass index. Smoking status, family history. Intermediate risk individuals may benefit from coronary calcium scoring or stress testing. Role of PDE5 inhibitors. Medications such as sildenafil and tadalafil improve erections by enhancing nitric oxide signaling. However, they do not reverse plaque. They are contraindicated with nitrates as they treat symptoms, not underlying vascular disease. Lifestyle modification remains fundamental. Lifestyle intervention, the reversal strategy. Evidence-based protective measures. 150 minutes weekly aerobic exercise. A Mediterranean diet, olive oil, fish, nuts, vegetables. Smoking cessation, weight reduction, blood sugar optimization, blood pressure control. Stress reduction. Studies show lifestyle changes improve erectile function and reduce cardiovascular risks simultaneously. Emotional and relational impact. It can lead to anxiety, depression, loss of self-confidence, relationship stress. Recognizing ED as a medical signal rather than a personal failure improves treatment outcomes. Final takeaway: erectile dysfunction is not merely a sexual health issue. It is often the first visible sign of systemic vascular disease. Your body may provide a 3 to 5 year warning window before a life-threatening cardiac event. Addressing ED early may protect your heart and save your life. References: Massachusetts Male Aging Study, a Journal of the American College of Cardiology meta-analysis, Princeton 3 Consensus Recommendations, American Heart Association Guidelines, European Association of Urology Guidelines. If you found this video helpful, don't forget to like, subscribe, and hit the bell icon so you never miss an update. We've got plenty more real talk on men's health coming your way. Thanks for watching, and we'll see you in the next video.